you very much, Tommy, for that kind introduction, and indeed for your interesting words. I'm very, very pleased that everyone is here this morning, and thank you very much for your attendance. A few months ago, when I did become Chief Executive of IFA, Irish Pharmaceutical Healthcare Association, I was fascinated. I wanted to find out what was going on and what our companies did and all that sort of good stuff. And one of the things I wanted to find out was what sort of supports do our companies give for patients groups, or patients themselves, for patient organisations, and so on. It was in the context of our appearance at the Oireachtas Health Committee. And from a quick trawl of our companies, I found out very, very many interesting programs that companies were involved in collaborations with patient groups. Of course, nothing could happen without the cooperation, without indeed the commitment of those patient groups, and there were true collaborations. But I found that there were 67 different patient organisations that our companies are happy to work with, and indeed privileged to work with. And I thought it would be a good idea, very simply, to gather together and to share some of those interesting lessons from collaboration and to see what we can build on for the future. And so that's what we're here about today, to see, not for us to tell you stuff, although it is interesting to bring you very interesting speakers like Graham and Gabriel from patients like me, but in fact to see what can we build on for the future. So this is the first thing we should do, is say hello. We're the Irish Pharmaceutical Healthcare Association, and let me briefly say that word healthcare is important. We're not the Irish Pharmaceutical Sales Association, and we're not the Irish Pharmaceutical Products Association. We're the Pharmaceutical Healthcare Association, and we have a critical involvement in the healthcare in this country. And indeed for nearly everyone who touches our healthcare services, particularly secondary services, it's critical what we do. We are 47 research-based companies, which basically covers just about everyone, and we'd like to have some more companies involved, and I'll talk to them too. But we are involved in just about every disease group, every therapy area, and in every type of possible treatment, and obviously essential for the conduct and for what clinicians do for patients. We provide thousands of essential medicines to Irish people, obviously. I tried to count them, but I couldn't. And you get into technical stuff to do with pack size and all sorts of things. But I think there are at least 1,000 patient protective medicines, and there's probably about 4,000 in the community drug scheme. But there are thousands, obviously. And our job is to bring proven new medicines to Irish patients fast. That's what I'd like to see our job to be, to do this quickly. There's no point in being slow about this. When we have proven new medicines, it's important we get them there fast. In 2014, for example, we brought in new medicines, fortunately approved and reimbursed by the HSE, and in a conservative estimate, there's about 700,000 people can benefit from those new medicines that were brought in last year. So what's a partnership? Because our day today is going to be a partnership. This is the philosophy bit, just for the moment. Transactions, counterparties. We can say our partnerships, and there's lots and lots of stuff to read about partnerships out there, but are they about buyers and sellers? If you just buy something, you go to a shop and you buy a bag of crisps or a can of Coke, are you in a partner with the retailer? Are they your partners in that transaction, or is it just a transactional thing? Or indeed, you could ask, is an employment relationship a partnership? Now, in recent years in Ireland, of course, we have said yes, employment relationships are partnerships. But they are essentially contractual, in terms of there's a buying and selling thing going on, or there is a sort of that type of a legal basis for a relationship where there is as the lawyers would say, a consideration involved. But there are lots of other ones. There's a regulator and regulated. Like, we would consider that we are partners with the HPRA, our lead regulator, and really important relationship for IPHA and for our members. And we sort of think, is that a partnership? Because the partnerships, the ones that are really important partnerships, which are non-transactional, where it's voluntary, where it's collaborative, where you build on shared goals, but you don't have an exchange, or you don't have a legal obligation in one way or the other, that you simply have to get involved in, like a regulator or a regulated. So you could really say that all of the above can fall under the term partnership, if we want. But today's ones, and I think the more important partnerships with patients' organisations for us are certainly going to be the ones in red there, about non-transactional, voluntary, collaborative, and about shared goals. Who are our partners? again, coming to this new role for myself, it's not that new, I'm about 5 months into it, you'd look and say, well, we have obvious partners which are based on the transactional side of things, if we allow that to be a partnership. So these are the transactions. Obviously, we have very important relationships with pharmacists and wholesalers, and we have very important relationships with the HSE, the Department of Health, and indeed, to a degree, with insurers who pay for our products or reimburse them eventually. And they are the core sort of transactional and regulated relationships. But, of course, all around us, we have relationships with all these different people and really, really critical players in delivery of healthcare services. Doctors, of course, this is very obvious. Doctors, hospitals, medical educators, like here today, the RCPI, the RCSI. We have a huge relationship, we want to have more with researchers, both in universities and through the organisation of research, such as the HRB. That's a really important stakeholder for us. We have the government, of course, both in terms of the Department of Health, but also, you might be surprised to know that we get a lot of interaction from the Department of Justice, from Environment, from DPER, that's Department of Public Expenditure and Reform. So there's quite a lot of parts of government that actually interact with us on their own volition to do with legal stuff. And indeed the Oireachtas, who make the laws which govern the provision of health services and indeed the way that our pharmaceutical products, our medicines are supplied and reimbursed. And there, of course, are the patients' organisations. Right there, a pretty critical relationship for us in many, many parts of the activities of pharmaceutical companies in the country. Now, something that binds them all together, of course, there is a sort of an organic whole to this. You could draw all sorts of lines between all those types of organisations because they all have their own relationships. You could flip the government, put the government in the middle and then draw the lines in a different way, or any other one, and all the lines go differently. But we are all bound together around this one big common obligation. And of course, the common obligation is to patients, which is the only thing which actually binds us all together in a sort of a really important way, that is the thing. Now, in the past, I suppose there's nothing wrong with saying that our common obligation to patients are about outcomes and welfare and safety. And people would have said in the past, and indeed now, without contradicting that's about they're the patients sort of down there, and the sort of that aspect of passivity perhaps in the past, and we are all these organisations, all these regulators, pharmaceutical companies, doctors, government, the whole lot, doing stuff to patients. But of course it is changing, because now we're adding things like patients' knowledge, we're adding patient empowerment, and these things are going to change. It's going to change the relationships with patients, it's going to change and is changing the relationships with patients' organisations, and of course, we only have to consider that any of us, and many of us are already patients. I am a patient, Tommy is a patient, lots of people, we're all probably patients in that sense. But in this day and age, and we'll come to it in the Patients Like Me presentation, we expect knowledge to be empowered, we expect empowerment, we expect a more balanced relationship with all those other players around that, within that circle that I put up there on the screen. So, and the involvement is that last part there, of course, and that involvement we'll hear from later comes importantly both in Graham's area in the research and in Gabriel's in this feedback mechanisms. So partnerships that work, I looked up, well, what makes a partnership that works? Look it up in the book and it'll tell you how to make a partnership work. But this is true. These are fairly obvious points. We have to have a clear common aim, very important, clarity on value and the necessity of the partnership. I think if we're going to have a partnership, any types of partnerships do rely on that you have to say, look, it is important that we actually work together. It's not just a nice thing, not just a sort of a thing that would be good, happy and good to do, but actually is necessary for the achievement of that common aim and actually contributes in a serious way to it. And I hope we'll hear from some of the patients' organisations who are actually speaking today when we throw it open and when we have the presentations that those things are true, that the partnerships that have worked are very much aimed at achieving, essential to achieving a specific aim. They need time and trust. This is important. These things, partnerships that work, collaborations, I'd be advised, you need to spend time at it. They don't happen quickly. And the more partnerships and the more collaborations we do, we have to realize that when we start them off, they're going to take time, and it's not going to be an instant hit, and it's not going to be, instant results or anything like that. And they need a lot of trust, explicit trust building steps and exercises to be put in place. Now, people would advise we need to share creativity, risk, responsibility, and resources. Well, that's quite an ask, because in terms of the resource imbalance may be there in terms of a lot of situations with the pharmaceutical companies, with smaller patient organisations, and so on and so forth. But it didn't say that there's an equal and sort of legalistic, division of resources. This is about sharing and about being explicit about that, how the resources happen, and indeed creativity, risk, and responsibility. And of course, clarity of information, consultation, deciding together, and acting together. Again, we'll hear from the actual working partnerships and working collaborations how much of deciding together and acting together is actually an important part of collaborations that are sustained and work. I think this will be true for all partnership type and collaborations, especially when they're not based on transactions, as I say, like buying and selling, employment and being an employee, or indeed regulation. Indeed, some of those ones you can't say a regulator can't act together, they have to act separately in those other relationships. But in these collaborative partnerships, you do have to decide together and act together. So what can work for us? Very briefly, here are some of my thoughts today. Well, first of all, companies do work with patients' organisations, do a lot of work, and IFA can do work with patient organisations. So we're the collective, and we are there with our 47 companies there as a collective organisation. So I have to ask myself, and our strategy board ask ourselves, right, what do we do as individual companies, and what can we best do together as a trade association and as an organisation? And we have to be very clear about those purposes. What is the best thing that IFA as an organisation can do to engender, to support partnerships with patient organisations? We're not going to be involved in disease-specific work, because that wouldn't be right, and companies can do that best themselves. But we have to be clear as to what type of arrangements do we put in place that is common across all the therapy areas. So clearly we want to focus on patient benefits, outcomes, understanding, knowledge, advocacy. And we're going to have a clarity of roles and do that according to ethical norms. Our IFA code has provisions in it relating to how we relate to patients and patient organisations. So when we focus on in the next 3 years, what can IFA as an organisation do better, and what is the essential role that it can play over and above what our individual companies do, these are the types of considerations that we'll have in mind. And we'll be interested to discuss with you and to hear back from you today what will work with these considerations in mind. Clearly, it's an obvious answer to say, look, let's do more adherence and usage support programs. I'd hear the word compliance around, and I sort of think compliance is not a word that appeals to me terribly much, but I like adherence better. Or if I was a patient, I'd like somebody to be supporting me in doing the stuff right, or using my medicine properly and all that, and getting the results out of it that those who designed them were hoping to get. But companies do this a lot, and we obviously, as IFA, we'd like to support more of this happen. We'd like to see more of it happen, and we'd like to show our stakeholders, indeed the government, the HSE, that this is what we do, and we have an important role in doing these things. But for the future, I think we're going to be heading more towards the area of feedback and real-world evaluation. Obviously, this fits really well with research, and Graham is going to speak just after me about what his plan for patient involvement in research. But the whole movement is towards not just obviously designing pharmaceuticals, designing medicines so that they can be used, but design them in advance, evaluating them in advance, doing the economics in advance. But it's also moving much more towards evaluating how they are actually used. and both for feedback for clinical effectiveness and feedback for the economic value of them. And this is going to be it's the key to unlocking how we're going to get new medicines available to patients earlier. Because at the end of the day, we can obviously the medicines are going to be designed from a therapeutic effect, from a basic biochemistry effect, all that sort of stuff from the biologics. They're going to be designed with a whole load of research going on beforehand. But the issue is increasingly becoming, as many of you will know, well, how do we decide from a reimbursement point of view? How do you decide in this collaborative work between pharmaceutical companies and those who pay for them? What are we paying for? Will they know they're getting value? The whole trend towards value-based healthcare and value-based reimbursement is going to need a lot of evaluation of the clinical effectiveness of the medicines in the real world, in real patients' experience, and indeed the economic effectiveness. I know with IPOSI, who today have helped us organise this thing, for which we're very, very grateful. IPOSI have done a lot of work over the last few years in getting patients involved in health technology assessments, which are fundamentally ex ante or before the usage. But the trend is going to be, and we'll hear more of it, that we're going to have a lot more of that evaluation happening after the medicine has been approved for usage. And it would be a very, very much more dynamic methodology for both us and the government to use, or the HC to use, to say, let's get the medicine in place early, let's do the evaluations as they are being used, let's readjust and go back and see, do we have the right type of reimbursement method in place, given what we're learning from the value that's being provided, or have we got the right type of clinical protocols and all that sort of stuff in place, rather than trying to guess everything or to anticipate everything from models only in advance. This type of real-world evaluation is going to obviously will fit with new technologies and patient involvement and outcomes and so on, and value. And the question for IFA and for us in the next few years is, how are we going to structure, how are we going to deal with this trend, which is going to happen, which is happening in other countries. It's going to be part of our world in the next few years, not in the next few months. But as I said, partnerships and collaborations are going to take time and trust. So if we were looking at what type of role could IFA as a collective organisation, collectively at the centre, play with patient organisations that covers every area, in my view it's much more likely to be in this type of area of what type of structures do we put in place and how do we support real world evaluations, real world patient involvement, patients' feedback, both for the better design of the therapies, for the better evaluation of what goes to make clinical effectiveness and safety, and for the better organisation of how they're paid for and how they're evaluated economically. And so there are my thoughts as we start the day. And I'm fascinated, I'm very, very interested to learn, because I am here to learn. I have learned fantastic things from the companies I work for, and I'm really interested to learn today from our speakers, from the presentations we're going to have. I'm very grateful for everyone who's doing those, and indeed to learn from the interaction, which is really terribly important for the rest of the day. So thank you very much and enjoy the day.